Okay, thank you everyone for your patience with us today. We've had a little bit of some technical difficulties, but it is the top of the hour, uh, a little over, but we'll go ahead and start. And before we start, we just want to remind everyone that this presentation is being simultaneously interpreted in Spanish and will be recorded. So to listen to the presentation in Spanish, please click on the globe-shaped icon at the bottom of the Zoom toolbar and select Spanish. And if you would like to follow along with the Spanish slides, on the top of your Zoom window, there is a tab that is labeled View Options. If you click on that tab, you can select Español for the Spanish slides. And this presentation has been approved for continuing medical and nursing education. And to receive credit, participants should attend at least 80% of the session and submit the post-session evaluation. And this is also true if you would like to receive a certificate of successful completion. We have no relevant financial relationships that relate to this presentation, nor do we have any relevant financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. And good morning once again. Buenos dias. My name is Pamela Secada Sales. I am the program manager for the Witness to Witness program at Migrant Clinicians Network and the facilitator for this session. We are happy that you all are here today. And I want to remind folks to please feel free to add any comments or questions in the chat. We will also have the Q&A feature. So if you want to use that, we'll have some time at the end of the presentation to answer some of those questions. Today's presentation, Post-Election Advocacy and Activism for Clinicians Serving Immigrant and Migrant Patients, is the third session of our Words Matter three-part webinar series. And in case you missed any of the live sessions, the recordings can be found on MCN's Archive Webinars webpage. And lastly, just a reminder, everyone will receive a follow-up email with the link to this PDF presentation and a link to the recording. And with that, I'd like to pass it over to Dr. Kata Weingarten.
Good morning, and thank you all for being here. We envisioned our Words Matter campaign 6 months ago when the election was still in the future. The results are now here, and the materials we have created, the 2 prior webinars in this series, and this one today could not be more timely. Our speakers will help us mobilize and take action, exactly what we need to do, if not today, in the days and weeks and months to come. Our speakers today have decades of expertise in their areas of focus. We have biographical information about them on our MCN, our W2W, and Words Matter web pages. And Melanie will say more about our speakers in a moment. What you cannot know, but what also matters, is how people respond when asked to provide a webinar, to meet deadlines, and follow the sometimes cumbersome requirements of another organization. Our speakers today are all very busy people with lots of demands on their time, and they responded to our call immediately, wholeheartedly, and they dotted every I and crossed every T, even ahead of time. We thank you so much. It's been wonderful to learn more about your stellar work, and we know we will learn even more today. Melanie.
Buenos dias. Good morning, everybody. I will start by saying a little something about my amazing colleagues. I'm blessed and privileged to be able to work with them. Germán Cadenas is Associate Director of the CYSCW at Rutgers University and an Associate Professor in Clinical Psychology. He is incredibly special for his professional work. He has super strong productivity. I'm going to share some publications as the webinar progresses with some links. But I think very important to this audience, in addition to his academic work, he has authored or co-authored 8 very important reports that inform treatment, best practice recommendations, evaluation of mental health, and coping in the undocumented community. And these reports have been disseminated in academic as well as community contexts. His work to improve the lives of undocumented people span not just psychological study, but also a lot of leadership and workforce development. And we have also some APA webinars, for example, that are fully and freely available online to look at best practices for working with immigrant populations. He also is very open and generous about his lived experience as an undocumented immigrant and connects in community his work with advocacy. Michelle Silva is also an incredibly accomplished scholar and a professor at Yale. She's had many grants, almost, I believe, 5 million in funding, if memory serves. And most of that work is applied, which I think, again, this audience will really appreciate. She's done direct work with the Connecticut Latino Behavioral Health System. She's developed computer-based training and CBT for Spanish-speaking alcohol and substance user populations, and has also, like Herman, built workforce capacity to address the needs of diverse clients. Her local action is exemplary, from advisory boards for the West Haven Community House Head Start program to the Mayor's Task Force on Unaccompanied Children. But she's also very active nationally through the American Psychological Association, and even internationally through her volunteer evaluator work for Physicians for Human Rights Asylum Network. And both of these folks are just 100% present 100% of the time. It's been a privilege for me to learn from them, and I'm really excited to introduce them to you and have you share in that opportunity with me. As we move forward into today's session, we discussed as a team how to get started today, and we wanted to collectively name the fear, the pain, the anger, and a host of other intense emotions that you might be feeling for yourselves, for your loved ones, and for those that we all serve. So we're very grateful to be in this space today and to build community with you and to build skills to strengthen each other, but also those folks that we serve. So in the spirit of that, we wanted to invite each of you to take a moment to consider, when you think about the immigrant community, what are you grateful for? And if it's possible, we'd love for you to put those words in the chat for others to see. And I believe that's possible. I see my chat here. Community. Nos organizamos y luchamos, si se puede. Resilience, wisdom, empathy. I know as an educator, I'm really grateful for the value for hard work and perseverance that I have witnessed immigrant parents instill in their children. I see hard work, strength, enriching. So these are beautiful points. Please feel free to continue to list them. And above all, continue to connect with this gratitude. And we hope as we move forward today that you can also join us in connecting with hope, hope for the future, hope that is sometimes hard to connect with, and that I think will be realized through the actions that each of us take in our work. So thank you. and I'll pass it on to my colleagues.
Thank you so much, Melanie, for that heartfelt introduction. And thank you to the Migrant Clinicians Network for hosting us today and for creating this important space at this time, at this very, very concerning time in our country and around the world. And thank you, everyone, for sharing some of your gratitude for the immigrant community. If I may invite you to take a deep breath as we continue, taking a deep breath and connecting with our breathing, with how we feel in our body, how we feel emotionally right now, as we center the gratitude for our immigrant community. This is our session outline. We hope to review some key terms, background context, to talk a little bit about the multifaceted role of clinicians when working in this context of immigration. And we will go over a model of collaborative immigration advocacy that we hope will be a way of getting involved in activism or advocacy locally, at the state level, nationally, in any capacity that makes sense to you in your situation. And we will end with some application and some case examples. So I'll pass it over to Michelle.
Good morning or good afternoon, everyone. I just want to echo the sentiments of my colleagues and also thank the two of you, but also thank the Migrant Clinicians Network for the opportunity to be part of this really important and timely webinar series. We recognize as has already been mentioned, the distress felt in the community, the distress also affecting many of us as we work firsthand in the community and see the impact, have, I think, felt in many ways what may happen should the outcomes be as they were, and are now in a position to have opportunities like this one to mobilize and come together and identify action steps while also being able to reflect on the impact of these recent events. So what I'll take you through next are some of our session objectives. We recognize that there are many places that we can probably go through within the hour that we have, and there's much more that we can say than we'll be able to. But we do have 4 main objectives for our session today. First and foremost, I think you'll see as a general theme is the opportunity to illustrate and think about the real life application of a model that was very much created and led by Herman and his colleagues as well on collaborative immigration advocacy, and really thinking about how we as clinicians, as partners, mental health providers in this work are also an affected party when we think about this the impact of policies and how that affects the work that we can do. So thinking through those primary components, but also how we apply those in the work that we do in the community. We'll also be talking about critical consciousness as a key term, but also how the reflection and the action can help improve overall client outcomes, both for individuals, but for communities as a whole. And the principles of how this, our outlook, when we think about critical consciousness and advocacy, is brought to life in these different spaces. And so a word about words, as this series is entitled, right? Words matter. And so we wanted to make sure that as we think about different terms that you'll be hearing about in our conversation today, there's some key definitions that we'll be using as we describe different concepts. So when we look at actually the anchor terms here on this list, as I was looking at them, we have policy-based trauma and harm and trauma-informed policymaking. And it's in some ways appropriate that they anchor this list because they are opposites of one another. So when we think about policy-based trauma and harm, we're referring to those formal and informal policies, structures that can lead to and often do detrimental effects, both physical, emotional, the impact that those policies, can have on individuals, on communities, and in some cases, irreparable harm based on the policies that are enacted. And so approaches like what we hope to present to you today are how do we transform the policies that exist and really think about through a trauma lens, how do we highlight resilience? How do we empower communities? How do we instill hope through the creation of policies that are intended to uplift communities? And recognizing that there have been systems of oppression that have not allowed that to occur. Immigration activism refers some to the multiple hats that we all wear. So when we enter these spaces, there is a definite opportunity and room and often obligation to identify what is our advocacy role and how can we be more involved as partners in recognizing what are the policies that are affecting our clients, our communities, how can we identify local resources and be ready to connect communities to what is needed. And so that's part of that activism hat that we all wear in these spaces. Critical consciousness.
Michelle, can I interject for just a sec? Excuse me.
Yes.
Can you just slow down a little bit for the interpreters?
Oh, yes. I'm so sorry.
Thank you.
That on the,
Thank you so much.
Chat. I didn't have it up. Yes. Do you want me to go back?
No, it's fine. You can just, you can proceed. Thank you.
Okay. I apologize for that. Critical consciousness. So when we think about that term, we're thinking about, it's been defined and really often discussed in the context of Paulo Freire's work, a Brazilian educator, and the concept of how do we increase awareness and recognition of how structures and systems have oppressed different populations, but not just recognizing awareness and the reflection of those pieces, but then how do we take concrete actions to transform that oppression into something that can actually empower communities. And so we'll be discussing that as well. And collaborative advocacy is really highlighting this model of how do we come together with communities and recognize that we are all equal partners and share space in the decision-making that comes from that partnership. So I will turn it over to Herman.
Thank you so much, Michelle, for the objectives and the key terms for today. I will speak very slowly, but please let me know if I need to slow down. And so first we'll begin by establishing the context a bit and the intersection of policy and clinical work, and sort of situate where we are in this moment, and where we've been in terms of the context of migration and anti-immigrant policy. And we, many of us who work in immigration often use butterflies in our, as a symbol, the monarch butterfly being a recognizable symbol of migration. So when we turn to the news, we often see news stories like this, right? And these are, for example, screenshots from news stories from within the past year or so, when there was an influx of immigrants at the southern border. We often hear about the migrant crisis or the immigration crisis. And likely we will hear about it more and more, that there's an immigration crisis. We've seen policymakers, including in this election cycle, take a rather anti-immigrant approach to telling us who they are on both sides of the aisle, unfortunately. Coming back to this idea that there's a border crisis, that there's an immigrant crisis. And I want to start by tackling that and really sort of unpacking that term, the immigrant crisis, and how immigration is talked about in popular media and in the macro policy narrative. I love to always say that humans have been migrating and moving around the globe for thousands of years. Since our origins in Africa, we started to move about to Asia, to parts of Europe, to Latin America, and all over the globe. And this movement, this migration, is a big part of the reason why we're still here today. Migration is part of our survival, it's part of our humanity. It is, in my view, a normal adaptive behavior. When we think about the monarch butterfly, it just sort of highlights how artificial borders are. Really, they are a construction, a social construction of humans. Global conditions are causing a rise in the numbers of immigrants all over the world. There isn't an immigration crisis. There are global crises that are causing people to flee their homes. They're being forced to move about the world. The United Nations estimates that there are 281 million immigrants globally. Let's see with that number for a second. 281 million immigrants globally. Folks who have had to move for a number of reasons. Economic instability, poverty, political unrest, war, right? We're witnessing a lot of global conflict for reasons such as crime, fears associated with their safety, and so on. And so all over the world, we're seeing that folks are having to relocate and to move somewhere else for safety and for refuge. And who wouldn't do that, right? To survive and to keep themselves and their family members safe. That was certainly the case for me and my family. We migrated when I was 15 years old from Venezuela, right at the start of the crisis there. And we were lucky enough that we were able to stay together in the United States, although there was no pathway for us to be able to adjust our status. And so we became undocumented. I was undocumented for almost 9 years. And this is the case for about 11 million people in the US who have no pathway. They have absolutely no legal alternative to being undocumented. There's no adjustment of status that is available to them. And so that is a problem. The US is home to 46 million immigrants. Our laws and policies are outdated, and they do not reflect the modern migration patterns or the global needs that are changing around the world in response to global crises. Our migration laws have not been updated in decades, and that is a real migration crisis. It's not about people moving or needing refuge. It's about the way that they are treated when they try to seek refuge and safety. It's really a crisis of our laws and policies. I also want to put into context, we'll hear when we hear about this notion of the immigration crisis, we'll hear about what different administrations have done. I want to contextualize in this global sort of climate of 281 million immigrants, about 1.2 million immigrants were able to enter the US through some of the current administration's programs, such as some of the programs that have allowed them to seek asylum at the border, and some of the humanitarian parole programs. That number may seem like a large number, 1.2 million, but it pales in contrast to the global numbers of 281 million immigrants globally. And so I want us to begin by thinking about these numbers and thinking about the scale and the issue not being migration and movement, but rather the way that immigrants are treated and our policies and laws not reflecting the real needs of the world and the country. We also know that policies to meet immigrants in the US have become more and more restrictive in the past couple of decades, and they do reflect xenophobic and racist biases. This is not my opinion. There's actually scientific research that has been documenting immigration policies at the federal level and at the state level, concluding that the US has an anti-immigrant policy climate. And I think that that's probably not a surprise to any of us. Right? And we're entering a phase where this might worsen, unfortunately. In the past administration, the past Trump administration, there were 470 policy changes that were documented by policy experts at the Migration Policy Institute. And these are some of the policies, right, that we might recall. The separation of families at the border, attempts to end the DACA program that protects about 800,000 young people from deportation and allows them to work in the US. Multiple travel bans, including to Muslim countries, Venezuela and North Korea. The end of temporary protected statuses, increases in rates and enforcement, changes in asylum rules, attacks on sanctuary cities in California, the sanctuary state, attempts to cut skill-based migration, right, for tech workers and workers who have a specialized skill set, and so on and so on. And so the current administration was not necessarily able to revert many of these policies. And in many instances, some of these policies were continued. Although there were some positive policies like the humanitarian parole program for some Latin American countries during the current Biden administration. So for the past 8 years or so, the federal landscape of immigration policymaking has continued to be quite anti-immigrant, unfortunately, when we look at it as a whole, paired with state policies that are anti-immigrant that have been multiplying all over the country. And we can think about Texas and Arizona and other states as the examples of these state anti-immigrant policies. As we think about this slide, I would invite us to take a moment to think about how we're feeling as we look at these policies and reflect on the racism and xenophobia that is embedded within policy at a structural level. Let's pay attention to how that sits with us. I know for me, it feels quite heavy. The policy context, when we think, for example, about the state of DACA, the DREAM Act, and how that program is in peril and has been in peril. The current administration was not able to provide a pathway to protect DACA recipients, and the program continues to be in peril. So, and this is the context and in which many immigrants in the U.S. Are trying to live their lives and to have some safety and some stability. But the context continues to shift and to become more and more aggressive and more hostile towards immigrants. So we can, as clinicians, we can see how this has an impact on the health and mental health of our immigrant communities. I'll pass it over to Melanie now.
Oh, gracias. Heavy indeed. So this is some of the scholarship that supports our understanding of the impact of public policy in health disparities. And I think, as many of you probably know through your applied work, these contexts impact people's mental health and well-being, and especially that of immigrants, refugees, and asylum seekers, but also their loved ones. I think it's important to note that for families in context of, for example, mixed documentation status, or in community circles where there is mixed documentation status, those that may have citizenship or residency actually show mental health and health impacts that are similar to those with undocumented status. So I think thinking about community is really important, and thinking about these sort of nested context, but specifically some of the things that we wanted to uplift in the next couple of slides. And if you want any of these references, please just reach out and we'd be happy to share PDFs and reports, where the high levels of trauma that we saw that were tied to immigrant status. And so, for example, during the time of the DACA rescission conversation, we collected data in a couple of different contexts, and we had trauma rates that varied from 40 to over 50% in the samples that we collected. And we're talking about samples of hundreds of folks who were either undocumented, had DACA, or were documented persons who had undocumented and documented folks in their social circles. There are lots of different pieces that we see that matter. For example, experiences with everyday discrimination and with food insecurity really had an impact on health and mental health. We saw in one of the reports with United We Dream and the Latinx Immigrant Health Alliance that in the thick of the pandemic, with the summer of civil unrest and the Supreme Court challenge to, or that's the challenge to DACA at the Supreme Court, our folks were reporting that their highest levels of stress were actually related to immigration status, even more so than the pandemic itself. And on this 7-point scale with, or 8-point scale, the ratings were at the very severe level for concerns about immigration. And then we saw how that same population, over 50%, had clinical levels of distress in some of the measures that we collected. So again, I think just big picture perspective, keeping in mind that these policies affect people's internal states and their communities and their relationships in ways that then have an impact on mental health and physical health for all. And I'll bounce it back. I believe Herman. Yes. Oh, that APA.
Thank you, Melanie. It gives me so much hope to see that there are over 130 people with us here today. And gives me so much hope to know that we are in a field where we want to promote mental health equity, where we want to work from social justice lenses, and we want to work in the community. And there's so much we can do in mental health to respond to this climate. In 2018, there was an interdivisional immigration project that involved 8 different divisions within APA and the National Latinx Psychological Association. We received a small grant, and the idea was to create a set of advocacy recommendations for mental health providers. And that's what we will present to you in a moment. We will come back to the model that emerged from this collaboration. That started in 2018 during a very difficult period, the last Trump administration, right? And again, I think the highlight here is that in difficult moments, I've seen our mental health field stand up and take action and respond in ways that are very helpful to our community.
Thank you, Edmond. So I will be very mindful of speaking slower this time again, and my apologies. So I have the opportunity to share some with you about the many hats or the multifaceted role of the clinician. And I'm excited to have a chance to talk about this because it's a part of my professional work that is very close to my heart, being able to be a clinician and being able to really have the opportunity to bear witness to, I think, what is often very challenging circumstances, but also to see the incredible resilience that our community has, and how these challenges can be transformed under even the most dire of circumstances. And so I would invite everyone on the call to really think about your role as provider, whatever that space may be, and to think about the various roles that you would say you have or think about in your day-to-day in this type of work. I would imagine that much of it may look like this, where it's very far from a linear experience. It's much more perhaps complicated, convoluted, ends up in the same place, but the road is not necessarily the most linear. And I believe that this is actually really parallel to the experience of many of the community members that we serve, where what perhaps they were anticipating that their reality would be like is far different than that expectation. And so when we think about the various hats that we wear, I'm reminded of the work of Dr. Falikov, who I believe was also one of your expert leads a few webinars ago, the last webinar, speaking about that multidimensional aspect of the work that we do. And so, yes, on the one hand, clinician is one piece of the work that we do, but in addition, we become cultural observers, advocates, inevitably in this space, educators, and many times we're introducing, I believe, that concept of mental health as we think about it here in the US to a community that perhaps has relied on very different sources of healing. Not necessarily, it's not a better or worse, it's just different. And there's an opportunity to really learn from those differences and integrate them in as part of our work. And so I bring these three questions to you of, how do you feel about having these various roles? What is it that each of you bring to this experience? And what is it that we need to know as a community of providers in order to feel better prepared to, again, not just reflect and recognize the challenges, but then use those to transform the structures and to transform not just individual people, right? But really, how do we transform into a system that can be responsive and respectful of the community that we're serving? And so we'll use these as guides, as moving forward, and as we think about the model that Hedman will share of where we see our space fitting. Pass it over to Hedman.
Thank you so much, Michelle, for these reflection questions. We also wanted to highlight that there are recommendations that already exist out there to guide our clinical work. I think this was in 2018, the California Psychological Association came out with recommendations for psychological practice with undocumented immigrants in California. We wanted to just point this out to you as a potential resource in clinical work. There's also the report from the APA Immigration Task Force from back in 2012, 2013, which was recently updated by the new Immigration and Health Task Force at APA, and that new report was launched in August. Another wonderful resource that summarizes the science and clinical recommendations. We wanted to spend some of our time today going over the model of collaborative immigration advocacy and that emerged from that interdivisional APA project that we mentioned a few slides ago. And again, the idea here is to have a guide for how to collaborate with our communities, with our local communities, and respond to anti-immigrant policies. And so the publication is here in case that anybody would like to read it in depth. But what we in this project, we had leaders from all of these divisions of APA and NLPA, and we engaged in critical dialogues with immigrant rights activists from across the country. And there were over 20 leaders, 20 organizations that participated in the project. And we held these regional dialogues. And after we did this, we created a report with our advocacy recommendations. And then we wrote this conceptual paper with our model because we thought it would be helpful for other clinicians and mental health professionals to see how we thought about this project and how we collaborated with the activists. And the model begins here at the top with the rectangle, beginning with that macro context of anti-immigrant policies, right? What we've been describing so far. This is the state of the world, right, at the moment, unfortunately, moving further into the anti-immigrant realm now after the election. What we understand is that these anti-immigrant policies are not only promoting trauma and harm within immigrant communities directly, that's the arrow that you see on the left-hand side, but that they also traumatize and create harm among the mental health and allied health community that is serving and trying to support immigrant communities in this context, right? So we're seeing the harm sort of multiplying. And as Melanie mentioned earlier, we see this within immigrant communities where there's a spillover effect, and immigration policies that are meant to stigmatize and to have a negative outcome on, say, undocumented immigrants, they end up having negative outcomes among mixed status families, immigrants of varying status, and among U.S. citizens as well. So there's a sort of a spillover effect from these negative policies. And so what do we do in this context? How can we position our work? How do we organize? How do we engage in activism so that we are not harming each other, right, as we do that? And so we created this model, the collaborative immigration advocacy model, with six principles that are grounded in literature and theory to kind of help us guide us along the way. So I'll go through each of these 6 principles pretty quickly. I'm seeing that the time is flying. But first, something that we think is helpful in working with immigrant groups, with immigrant communities, with activists, with leaders, is to approach the work using a democratic and egalitarian leadership structure. And we reviewed some of the literature linking transformative social movements, such as the movement for racial justice, right? The civil rights movement, the movement for peace, Gandhi's liberation movement, and the feminist movement. They all tend to embrace, all of these movements for social justice tend to embrace a democratic and egalitarian leadership structure where decisions are made by the group and power is shared among the group. So we thought that this is important when trying to engage in activism alongside immigrant communities, and that we don't enter these spaces from a place of expertise or a place of higher power, but that we'd rather enter the space in a collaborative way, sharing power, perhaps sharing the expertise or specialization that we have in working alongside immigration activists. Something that was really key in this model as well is to center and uplift immigrant voices to make sure that we create the space for narratives to be shared to facilitate empowerment and empathy. We know from liberation frameworks, as well as the newer emerging frameworks for racial and radical healing, that narratives are connected to healing, to gaining agency and self-determination. And so this is a key, I think, sort of principle for this collaborative advocacy that we create the space for the narratives to be shared. Something else that we found very helpful is to work in a very local context. And so we have these national policies, and there's also state policies, and often times we have the most power and influence within our own communities, within our own neighborhoods, within our institutions, within our families or social networks. And the idea is to create teams that are locally based to collaborate in relation to activism. In our case, we form regional teams. But I would certainly recommend trying to connect with your local immigrant rights organization, your local immigrant serving org, and trying to locate the impact in as local of a way as possible. Another component of the model is facilitating critical dialogues. Understanding that dialogue is a central method for facilitating spaces that are liberatory and oriented towards social change. And this is something that critical consciousness theory from Paulo Freire, as well as liberation psychology from Ignacio Martín Baró, have in common. Both of these theoretical approaches center dialogue, and really it is in dialogue with each other where we can enhance our critical consciousness or reflection of systemic oppression, and also gain the agency and the confidence to take steps, to take action, to try to address this oppression. Another piece of our activism advocacy model is to center trauma and empowerment at the same time, understanding that traumatization is unfortunately common among immigrant communities because of the global and policy conditions. As Melanie mentioned earlier, the degrees of trauma are quite high. And the idea is to create a space where folks can identify, name, and observe, witness the trauma among each other, and that practice can be restorative and healing. At the same time, ensuring that we have a pathway to connect folks to care in case that very high levels of trauma become activated. So when we facilitated these dialogues, there were licensed folks present and ready to work with anyone who might have become activated, and to also facilitate a referral if needed. And then the last step is to develop advocacy strategies. And so the idea here is that after we've established a democratic structure, centered the voices of immigrants, we've kind of understood and responded to the local context in groups. After we facilitated critical dialogues that center trauma and empowerment, it is at that point that we can then begin to imagine what action and activism can look like, and to have that be guided by sort of the shared impact and the shared empowerment that we may we may discover through this process. And so the idea is not to like impose an advocacy agenda on a community or a group, but rather to kind of discover the advocacy agenda through this collaborative process. And for implementation, we published this report, which is public on the Society of Counseling Psychologists website. We also shared a report with advocacy organizations, with the American Psychological Association, and with many other groups. And these are some of the national strategies that emerged from applying this model from our project. Policy at the advocacy level nationally, some recommendations for service delivery and programmatic level changes, as well as training and education level recommendations. And the idea is that we can apply this model wherever we are in the country, in whatever state where we live, even in any setting where we work, whether it's a hospital or healthcare setting, education within the school systems or higher education, or in the community. And we can use this model to guide how we engage with local immigrant groups to develop an advocacy strategy. Okay, and with that, I'll pass it back to Michelle and Melanie.
Thank you, Herman. So in the time that we have left, we want to share a couple of examples of this model at work. And so we have two. Melanie will share about the United with Dream collaboration, and I'll tell you some about a community health worker program in Connecticut.
Did you want me to jump in? I think I'm noticing time is super, super tight. I think the work with United with Dream has been very much in collaboration at every step of the way. So thinking to Herman's model, just really in keeping from the very moment of conceptualization. I think we came together and asked, what do you need? How can we help forward your mission? They have an UndocuHealth program that I've tried to put some links online to and put some information in the chat. And when we ran our report, the big report, that was really the culmination of years already. We had been doing information sheets and disseminating them to the community. We have in the lower left-hand side, you can see we had sort of brought together the National Latinx Psychological Association and United We Dream, and then continued building that, always being responsive to community needs. And I know, so we helped develop a mental health directory directly in response to United We Dream's request that we help identify providers, but also many of us have participated in webinars and Instagram lives and things that I probably can't even report very accurately on, but basically online platforms to reach folks, either leading spaces of reflection or spaces of information, echo sessions. And I think at every step of the way, it's just sort of using our location to help pull together the resources that we need and create a shared vision for how and what could be a positive in the community. And it's been an incredible collaboration. What else would you add to that, Herman or Michelle? Because you've been there every step.
Yeah, I think that's a great summary of how seeing it in action and really putting these various components together. And I know that we're short on time. And thank you, Pamela. I see your message now in the chat. I would just add very briefly to share about the CHW program. And I mention it because work Herman was mentioning, one of the recommendations that came out really highlighted from one of the regions, the importance of psychoeducation and really promotoras de salud. And I'm sure a concept that many of you on the call are familiar with, are working on, have created. And so in Connecticut, we have a system that's called the Latino Behavioral Health System, where the goal is expanding mental health services for the Spanish-speaking community. And the CHW program is an expansion really along those lines of saber es poder is our model, right? So our goal is to go into the community to identify community members with that lived experience who can speak the language. And it's not to identify more clients. We're not trying to increase the census in the local clinics, but it's really to meet individuals where they are in the community, to learn from the wisdom that is there, the wisdom of healing, of how people understand the causes of what may be happening, thinking explanatory model as what are the causes that are seen, and then that will help inform them the solutions. And so this community health worker model operates in the spaces that people are in the libraries and an elder care center with Spanish-speaking folks, at a social service agency. And the pictures here, as you can see, is how there's a group format, because we know that the collective power of having people together to share their lived experiences. And the group themselves have developed different coping strategies. So what we think about, we teach, in a clinic session, perhaps, you can see there's some cards that they put together with, closing your eyes, visualization techniques, but really promoting mental health literacy in spaces that perhaps it hasn't existed before, but reducing stigma is part of it, but also just healing within the group, without having to pathologize what is a expected response to some very stressful, unfortunate situations. And so I know we're exactly at the 2:00 mark, and with not much time for questions. Pamela, it sounds like you're going to jump in.
Yes, thank you. And I just wanted to say we did run out of time for the Q&A, but if folks have any questions, you can email me and I will connect you with the presenters. And I dropped my email already in the chat. You will be getting a copy of this presentation and with the link to the recording. We invite you to stay connected with MCN. I'm going to breeze through these just for sake of time. And if you, please, if you can complete the evaluation, I'm going to drop the links here in the chat as well. We appreciate your feedback and we value your feedback and appreciate it. So if you could please complete that evaluation for us, that would be great. With that, I want to thank our presenters, everyone involved with this presentation. Thank you so much. Thank you for your patience with all our technical difficulties. We hope that the presentation was useful for you and hope to see you soon. Thank you, everyone. Thank you to our presenters.
Thank you, everyone.
Thank you so much.